So this year we've seen some very exciting data in HER2-positive disease and in ER-positive disease, leading to the approval of pertuzumab and everolimus. And I think that we've really started incorporating these drugs into clinical practice. The approval for pertuzumab is fairly narrow, first-line therapy with docetaxel, but in the NCCN guidelines, it's any taxane, which I think is very reasonable, and we've all incorporated that, along, of course, with trastuzumab. I think that what we're seeing is a lot of enthusiasm about the affinity trial in the adjuvant setting and in incorporating these drugs into clinical trials in the neoadjuvant setting, because our goal is really to cure patients of HER2-positive disease, and it seems like that's a very achievable goal, maybe, because we now have more and more effective drugs. We're also, of course, fascinated with the results of trastuzumab DM1 or emtansine, in comparison to lapatinib and capecitabine, and that drug is also moving into the neoadjuvant and adjuvant settings, and I think we'll see a lot more of the drug. I expect it to be approved early next year. In terms of everolimus, we're learning how to manage toxicity better, which is really important when we're using this drug in the metastatic setting. But one of the important things that the approval of everolimus and, of course, the exciting BOLERO-2 data has led to is an explosion of studies trying to identify biomarkers that predict response, and also a huge number of new agents that are being tested in this setting, which I think is the most exciting area, because we need biomarkers and we need to understand how to even move further ahead.